Today we'll be discussing insulin management in the ICU or in the ward. We will particularly focus in the subcutaneous insulin, right? Suppose a patient comes to you, a diabetes mellitus type 2 patient, and he is on oral hypoglycemic agent. Now in the ICU or in the ward, in the hospital, we cannot give oral hypoglycemic agent. So what we have to do? We have to change it to subcutaneous insulin or IV insulin based on the requirement. We will basically be discussing on subcutaneous insulin today, right? So before going to discuss the insulin part, we have to understand the physiology of the insulin inside our body. So let us learn that. This is time, this is insulin. So at any point in our body, we have a basal insulin going on, right? And this insulin is essential to maintain a constant level of blood sugar in the blood. Especially the fasting blood sugar is maintained by this insulin. This is called basal insulin, right? And as we eat our meals, suppose we eat our breakfast, so immediately there is a glucose overload, so immediately there is a spike in the insulin secretion. This is called prandial spike or postprandial spike of insulin, right? And again at the time of lunch, the time of dinner, we'll have these spikes of insulin, and these spikes are called bolus insulin, right? So our purpose is to emulate this physiological function of insulin in our body. Let's say the same person, the same patient, body weight is 60 kg, right? So as a general rule, you have to remember that the normal insulin requirement in a patient per day is around 0.5 unit per kg per day, provided he has no comorbidities, right? So no, so here it is 0.5 unit per kg per day. And patient who has comorbidities like CKD, CLD, very elderly, cachectic patient, in this kind of patient, you take a little lower dose of insulin, that is zero point 0.4 unit per kg per day. So for our patient who do not have any other comorbidities, we will take zero point 0.5 unit per kg per day. So 60 into 0.5, that is 30 units of insulin you will require per day. As I've told you, the insulin has to be divided into basal and bolus, right? So we have the patient who requires 30 units per day, and it has to be divided by basal, that is 50%, and bolus, that is 50%, right? So 50% of 30 is 15 unit basal insulin and 15 unit bolus. This 15 unit we have to divide into three parts, right? Before breakfast, before lunch, and before dinner, right? And divide this 15 into three parts. So 5 unit bolus here, 5 unit bolus here, and 5 unit bolus here. Now this is done. So is it enough? Is this basal bolus regimen is enough? Let's see an example. We'll take the same graph. This is time, this is insulin, this is basal insulin, this is postprandial insulin, right? This is before breakfast, this is before lunch, this is before dinner. So let's say before lunch we check the blood sugar. The CVG came out to be 280, right, milligram per DL. And at lunch we are supposed to give our fixed dose insulin how much? Fixed bolus insulin how much? 5 unit. Then we eat the meal, and the meal suppose increase our blood sugar by let's say 100 milligram per DL. Now see here, this bolus, fixed bolus we gave before eating is to cover for the hyperglycemia that is happening after we eat the meal. But what about the already heightened level of blood sugar in the blood? Who will cover for that? So that is the reason why there is a concept that is called top up insulin or correctional insulin. Why it is top up? Because you have to top up above the fixed or bolus dose. Why it is correctional? Because the insulin that you have given in the morning was not enough. That's why the sugar has gone up to 280. So we have to correct that. That's called correctional insulin. So how do you find how much top up insulin has to be given or how much correctional insulin has to be given? So we have to find out the correction factor. Right? What is correction factor? That is 1800 divided by total daily dose of insulin. In this case we have 30 units. So 1800 by 30, that is 60. That means 1 unit of insulin will decrease blood sugar by 60. So similarly we'll write 2 unit of insulin, it will decrease by 120. 3 unit of insulin decrease by 180. 4 unit of insulin will decrease by 240, right? So this is our correctional scale, right, of insulin requirement. Now again applying here, so let's see with the same patient, so we have 60 kg and zero point 0.5 unit per kg per day, that is becoming 30 unit. We divide that into two part, 15 unit basal and 15 unit bolus. This bolus is divided into three part, 5, 5, 5, that is before breakfast, before lunch and before dinner, right? And what happened, so you have 15 unit bolus and we gave 3 5 unit each, and our target blood sugar is, let's say one amount is around 120. So breakfast time, so this is breakfast, we check the blood sugar and it came out to be 280. The lunch time we check the blood sugar, it came out to be 160. The dinner time we check the blood sugar, it came out to be 300, right? Our target blood sugar is 120. So what is deficit? 280 minus 120, so that is 140. Here it is 40, here it is 180. So this much of sugar is extra each in our meal. So this insulin that we are giving was not enough to control the blood sugar. So here we have to top up the insulin. How? As I have discussed here, for 1 unit of insulin it decreases 60. So for 140 it is between 2 and 3. So we'll take the higher side. So we need 3 unit extra. For 40, 1 unit, we need 1 unit extra. For 180, it is 3 unit extra, right? So this is called top up insulin or correctional insulin. What is our fixed dose insulin? 555. So we add that, add to fixed dose. So top up plus fixed dose. This is the column. It will become 5 into 3 8 unit, 5 plus 1 6 unit, 5 into 3 8 unit, right? So before breakfast you have to give 8 unit, before lunch you have to give 6 unit, before dinner you have to give 8 unit. Despite our calculation that patient requires 555, this is called correctional dose of insulin. Now what is the total top of insulin we have gathered in one day? That is 6 and 7, so this is 7 unit, right? Now what will happen in the next day? This 7 unit has to be incorporated into the basal bolus regimen, right? How? Same. So 60 kg, zero point 0.5 unit per kg per day, that is 30 unit, that is becoming 15 unit basal and 15 unit bolus. So 5 5 5 5 5 and 5, right? So there are two schools of thought here. Basically, one school of thought, another is mine invention or what I do in my ICU. Because as I've discussed you, the fasting blood sugar is maintained by the basal insulin. So whatever top up is required at the breakfast time, that to add to the basal insulin, that is becoming 18 unit for the next day. This is day 2. This is day 1. And the rest 4 unit. So the breakfast time along with Lantus we've given the 3 unit of top up. So we there are 4 more units remain. They have to divide into 2 here and 2 here. That's becoming 7 unit, 7 unit. So in the morning, in the breakfast, patient receives 18 unit of basal insulin. Then in the lunch, patient receives 7 unit. Then in the dinner, patient receives 7 unit. This is day 2. Here also, the same thing. You have to measure blood sugar before breakfast, CBG, before lunch, CBG, before dinner, CBG, and find out how much is extra, how much extra blood sugar we have to correct. Then, depending on that, you have to use the correction insulin on day 2 also. So, there will be top up insulin. So, this top up insulin like this in day 3 we have to add. So you'll find after day 3, day 4, you'll find a balance, an equilibrium. That is the insulin that you are going to continue for this patient, right? So this is the concept of how to calculate basal and bolus insulin for a patient. Some group of physicians, what they do, whatever unit they have got, for example, the 7, so let's say it is 8 for the sake of calculation. So they will divide into 2, 4, 4. So 4 they will add to the basal, and another 4 would be divided into 3 parts, 1 1 2 or 2 1 1, and into the bolus regimen. That also can be done, right? So that will become 8 means 4, so total is 8 unit, so 4 here, so this 19 unit, and 3 here, so it will become around, let's say 8 2 7 1 6 6 the next second day. In my procedure it was 18 and 2 2. So it is very much physiological because the fasting blood sugar is controlled by the basal insulin. So it is very physiological to aid the fasting correctional dose of insulin to the fasting, to the breakfast meal, right? So this is how you calculate the basal bolus regimen. Now how to choose which insulin we have to give, let us discuss that. So as you have seen, the separate insulin divided into two parts. One is basal, one is bolus, right? So in the basal insulin and in the bolus insulin, what to choose? So general principle we have to remember before deciding on what insulin we are gonna use. That is, in ICU we avoid longer acting insulins, at the same time very short acting insulin. Why? Because of the dynamicity of the patient's clinical condition. For example, the insulin requirement may increase. For example, patient you gave patient steroid, patient developed sepsis, right? There is shock. So the requirement of insulin may be decreased or increased based on your intervention. So if you give a very longer acting insulin, suppose you are going to do a procedure and you have to keep the patient NPM. Now you have already given the longer acting insulin. So there is risk of hyperglycemia, right? Or very short acting insulin, what will happen? You have given the insulin, but some of patient not able to take the food. There is feed intolerance. So what will happen? There will be hypoglycemia. So as a rule, we generally avoid very long acting and very short acting insulin in the ICU because of the dynamicity of the clinical condition, because the patient's insulin requirement may change on hourly basis, right? Let's say, so that is the basic principle. On this principle, let us decide what insulin we can give out to our patient, right? For basal insulin, there are basically two types, right? One is Glargine. In the Glargine, we have Lantus, we have Toujeo. Lantus is long acting and Toujeo is ultra long acting. So by definition, we do not use Toujeo in the ICU, right? It is long acting. It is ideal for NPO. Even if you are doing a procedure, it's only 24 hours. So you can stop it without risking for hypoglycemia. Once daily dosing, Toujeo dosing 136 hours, 42, 48 hours. The patient clinical condition change drastically during that time, right? And it is well studied. This is one of the important point. There are many research papers, many studies are there on Lantus. So in the ICU, I generally prefer the Lantus insulin, right? And I do not choose the Toujeo insulin. This is basically can be given for OP basis, in outer basis at home, where patient hemodynamic status, clinical status is almost same. And there is another Degludec. It came in the name of Tresiba. It is also ultra long acting. This I do not prefer this in ICU. This is OP basis again. Right. So in the ICU, I prefer Lantus. That's a long acting and well studied, ideal for NPO and once daily dosing. So if you have to choose one insulin in the ICU, it is Lantus insulin for basal. This is what I do in the ICU, right? And what about bolus? Bolus we have Aspart insulin, and Aspart insulin come in two part: Novorapid and Fiasp. Fiasp is ultra short acting, and this is short acting. Again, by the principle ultra short acting, we do not prefer it in ICU. This is mainly OP basis, where we have a stable clinical condition, stable meal pattern, everything is normal. So Novorapid is less mismatch, less hypoglycemia, and it is much more studied. Sick patient in the ICU who are on trials to feeding, it is better for them. So you'll find many patients will be on active feeding like 120 ml second hourly or 140 ml second hourly. In those patients, because the blood sugar spikes every second hourly, we cannot give a agent which is very ultra short acting, because then if you hold the next meal, there will be hypoglycemia. At the same time, if you give Novorapid, this secondary change of insulin will be well taken care of without causing hypoglycemia. So patient on active feeding, choose Novorapid. Patient improved. Patient improved. Now patient is not on trial feeding, he is on a feeding that is 3 times a day. Breakfast, before lunch and before dinner. There you can choose Fiasp insulin, the ultra short acting insulin. Fiasp. Because now the meal has been regularized, patient is healthy, they are taking their usual meals. Even if you give ultra short acting, there is no reason to be becoming hypoglycemic. Right? So regular meal, Fiasp insulin, relative feeding, Novorapid. Of course, we have another kind of insulin that we do not use frequently, that is Lispro insulin, comes under the name Humalog, generally do not use. And then we have regular insulin, that is called human Actrapid. It is solely reserved for IV use. Do not use this in Basal-Bolus regimen. It is solely used for IV use. So patient is sick, on vasopressor, shock, give IV insulin. Patient is sick but not on vasopressor or not in shock, use basal plus bolus. In the basal, use Lantus. In the bolus, because patient is sick on to feed, on active feed, use Novorapid. Patient now improving on regular meal 3 times a day. Now use basal plus bolus. Here I prefer Lantus and Fiasp. Right? And IV insulin is human Actrapid. So this is the final prescription of our patient. So today we discussed the insulin management in the ICU, especially the circuit insulin. I hope you like this lecture. Please share and subscribe to my channel. Thank you very much.